Hello friends, in this video I will discuss about chemotherapy of malaria, the anti-malarial drugs and its pharmacology. Malaria is still prevalent in many countries including India, and the student of MBBS and MD pharmacology, they should have a basic idea of anti-malarial drugs and principles of chemotherapy of malaria. So I will discuss first what are the learning objectives in this section. Treatment of uncomplicated malaria, treatment of complicated malaria, classification of antimalarial drugs, artemisinin based combination therapy, and pharmacology of some important antimalarial drugs such as chloroquine, quinine, and primaquine. So, malaria remains a major health problem in countries like India. It is caused by infection with protozoa, that is Plasmodium. 5 Plasmodium species are known to infect humans, and those are Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, and Plasmodium knowlesi. Plasmodium falciparum and Plasmodium vivax, these are the two important infections worldwide. But the major concern is drug resistant to antimalarial drugs. So this is important to use the antimalarial drugs according to national treatment guidelines. Before we proceed to the drugs, we should have a basic idea of life cycle of Plasmodium. So you can see in this diagram that life cycle of Plasmodia consists of two phases, one part in human and second part in mosquito. So the asexual replication occurs in humans while the sexual cycle is completed in the Anopheles mosquito, female Anopheles mosquito. So you can see in this diagram that sporozoites are the infective stages for humans, and these are released from the salivary glands of the female Anopheles mosquito into the human body. They reach into hepatocytes where they undergo pre-erythrocytic schizogony. The stages liberated from hepatic cyzones, they invade the RBCs, and in RBCs erythrocytic schizogony is operated, which releases merozoites and some toxins that are the cause for fever and chills in the malaria. Some of the stages from RBC, they undergo next development in the mosquito. So microgametes are formed, and these microgametes are taken up by mosquito, female Anopheles mosquito, and these stages develop further after fertilization, that is zygote formation and development into ookinete and finally into sporozoites in the mosquito. So in this way the cycle is completed between human to mosquito, then again human. So you have to remember this cycle because anti-malarial drugs are acting on a particular stage of the cycle. So this is a simplified version of the life cycle of Plasmodium. So I will skip these slides because I have given a basic idea of life cycle. One important point that you have to remember that erythrocytic schizogony lasts for 24 hours in Plasmodium knowlesi, while 48 hours in Plasmodium falciparum, vivax and ovale, and 72 hours in Plasmodium malariae. That's why this is responsible for the characteristic fever pattern in the malaria. Now coming to the drugs. Classification of drugs is very important. Anti-malarial drugs are classified chemically as well as according to their mechanism of action or the stage of cycle. So chemical classification consists of 4 aminoquinolines, the drugs are chloroquine, amodiaquine. 8 aminoquinolines, the drugs are primaquine, tafenoquine. Quinoline methanols, the drugs are quinine, quinidine, mefloquine. Amino alcohols, the drugs are lumifantrin, halofantrin. Biguanide, proguanil. Sulfonamides and sulfones, the drugs are sulfadoxine, sulfamethoxypyrazine, and dapsone. Diaminopyrimidine, the drug is pyrimethamine. Antibiotics, tetracycline, doxycycline, clindamycin. Sesquiterpene, lactone, artesunate, artemether, artether, arterolane. Naphthalidine, pyronidine. Naphthoquinone, atovaquone. So it is not really possible to prevent infection because no antimalarial drug kills the infective stage, that is sporozoites. Drugs can only prevent the development of symptomatic malaria caused by asexual erythrocytic forms. And no single antimalarial drug is effective against all hepatic and intraerythrocytic stages of the life cycle. So complete elimination of the parasite infection therefore may require more than one drug. The second way of classifying these drugs is clinical classification. Drug treatment is malaria is aimed for prevention of acute attack, that is the prophylaxis. Second, treatment of acute attack, that is the clinical cure. Third, radical cure, that is to completely eradicate the parasite from the body. And fourth, prevention of man to mosquito transmission. So we will see in the next slides how this is achieved. So if you remember the life cycle of the parasite from the previous slides, causal prophylactics, they act on the pre-erythrocytic stage of the parasite, while suppressive prophylactics and clinical curatives, these antimalarial drugs, they act on the RBC stages, that is the erythrocytic schizogony. Radical cure, it is achieved in Plasmodium vivax and ovale malaria, and the drugs acting on exoerythrocytic stage or hypnozoite stage, they cause radical cure in malaria. For prevention of transmission to mosquito, gametocyte stage is the target. So in this way you can remember the site of action of drugs in the life cycle of Plasmodium, how the drugs attack at a particular stage in the life cycle. So among the causal prophylactics, these target the pre-erythrocytic schizogony or tissue scizones, and they prevent the cause of malarial attack. The drugs are primaquine, proguanil, atovaquone, and a fixed dose combination of atovaquone and proguanil, that is Malarone. Suppressive prophylactics, these drugs they target the RBC stages, that is the erythrocytic cyanotocytes. They prevent the clinical attack of malaria, and the drugs are chloroquine in the sensitive areas, but the preferred drugs are mefloquine and doxycycline. Then we have clinical curatives or the drugs acting on the RBC stages, that is the erythrocytic schizogony, and these drugs, by killing these stages, they are classified into high efficacy drugs and low efficacy drugs. High efficacy drugs, antimalarial drugs includes artemisinin, chloroquine, amodiaquine, quinine, mefloquine, lumefantrine, halofentine and atovaquone, while low efficacy drugs are proguanil, pyrimethamine, sulfadoxine, doxycycline and clindamycin. Now this slide is very important. If there is mixed infection of Plasmodium vivax and Plasmodium falciparum, it is treated as Plasmodium falciparum malaria, and it consists of artemisinin based combination therapy plus 14 days course of primaquine to prevent relapse. You have to remember one thing that is important, that is relapse occurs in Plasmodium vivax and ovale malaria, not in Plasmodium falciparum. But if there is mixed infection, the treatment is given according to Plasmodium falciparum malaria, and 14 days course of primaquine is given to cover the relapse of malaria due to Plasmodium vivax. If malaria due to Plasmodium vivax occurs in pregnancy, the drug of choice is chloroquine, but primaquine is postponed till delivery. Primaquine is the radical curative because it attacks the exoerythrocytic stage of the parasite. Plasmodium falciparum malaria in pregnancy, the preferred drug is quinine, that is 600 mg 3 times a day for 7 days, plus clindamycin 300 mg 3 times or 4 times a day for 7 days. It can be used in all trimesters. Second option is artemisinin based combination therapy, 3-day regimen. It can be used in second or third trimester. So this slide is very important, how to treat mixed infection or malaria in pregnancy. For severe and complicated Plasmodium falciparum malaria, this can lead to black water fever, renal failure and cerebral malaria. The drug of choice is intravenous artesunate. If there is first trimester of pregnancy, then the drug of choice becomes intravenous quinine. As I have mentioned earlier, that radical curative is needed in Plasmodium vivax and Plasmodium ovale malaria, and they attack the exoerythrocytic stage, that is the hypnozoite. Fortunately, in Plasmodium falciparum, no exoerythrocytic stage is seen, so radical curative is not required, and the drug is primaquine 15 mg daily for 2 weeks in patients without G6PD deficiency in Plasmodium vivax and Plasmodium ovale malaria. Tafenoquine is a new longer acting analog of primaquine with short duration and short course. Then gametocidal agents, these drugs, they prevent the transmission of Plasmodium stages from human to mosquito. So in case of Plasmodium vivax and ovale, the radical curative primaquine covers the gametocidal transmission also, gametocide transmission to mosquito also. But in case of Plasmodium falciparum, we have to give single dose of primaquine to cover transmission of gametocide stage to the mosquito, from human to mosquito. So in case of Plasmodium falciparum malaria also, a single dose of primaquine, that is 45 mg, is given immediately after clinical cure to act as gametocidal agent to prevent the transmission of gametocytes from human to mosquito. We all know the clinical features of malaria, and clinical manifestations of malaria include high spiking fevers and chills, headache, myalgias, GI symptoms, gastrointestinal symptoms, anemia, diminished consciousness, seizure. Complications may arise such as pulmonary edema, rarely splenic rupture, acute lung injury. Plasmodium falciparum malaria, it is the most severe disease and may lead to organ failure and death. Plasmodium vivax malaria usually has low mortality rate, and relapse in Plasmodium vivax is caused by the reactivation of hypnozoites, that is the dormant stage of Plasmodia. Relapses may also occur in Plasmodium ovale. Now discussion of anti-malarial drugs. So chloroquine, it is the preferred drug in chloroquine sensitive areas, and the mechanism of action includes a rapidly acting erythrocytic schizontocide against all species of Plasmodia. Patient becomes afebrile in 24 to 48 hours, but it is not effective on hypnozoites or exoerythrocytic stage, and it has no gametocidal activity. Mechanism of action of chloroquine is that, you can remember by this diagram, that hemoglobin is broken down to globin and heme. Globin is utilized by the malaria parasite, and heme is toxic for malaria parasite, and it is converted by heme polymerase to hemozoin. But chloroquine, quinine and mefloquine like drugs, they inhibit heme polymerase and they cause accumulation of toxic heme. So this is the mechanism of action of chloroquine, quinine and mefloquine like drugs. You have to remember one thing, that they prevent the conversion of heme to hemozoin, leading to accumulation of toxic heme, that is toxic for malaria parasite. Other actions of chloroquine are anti-inflammatory action. It is used as disease modifying anti-rheumatic drugs in rheumatoid arthritis, activity against Entamoeba histolytica and Giardia lamblia. In pharmacokinetics, you have to remember that the drug is accumulated in some tissues. Retinal toxicity can occur due to accumulation in retina after prolonged use. It is a drug having large volume of distribution, so loading dose is given. It is not to be injected intramuscularly due to local toxicity, and usually not given by IV route also. If it has to be given by IV route, then a slow infusion is given in divided doses. The tablet of chloroquine phosphate consists of 250 mg, which has 150 mg of actual chloroquine base. Tablets should not be chewed because it is very bitter in taste, can cause severe nausea and vomiting. Adverse drug reactions to chloroquine include nausea, vomiting, can be severe anorexia, pruritus, epigastric pain, headache, visual disturbance, insomnia, skin rashes. Intravenous chloroquine can cause hypotension, arrhythmia, cardiac arrest, convulsions, High doses can cause peripheral neuropathy, myopathy, cardiomyopathy, ototoxicity, behavioral changes. And this drug chloroquine is safe in pregnancy, so it is the preferred drug in the uncomplicated Plasmodium vivax malaria during pregnancy. How to use this drug? In Plasmodium vivax, Plasmodium ovale and Plasmodium malaria, it has to be used in 3-day schedule. The first day schedule consists of chloroquine 1 gram, that is 4 tablets of 250 milligram chloroquine phosphate, or you can say 600 milligram base, first dose, followed by again the same repetition of the same 4 tablets of 250 milligram, that is 600 milligram of chloroquine phosphate, and on the third day 0.5 milligram, that is half of the earlier doses, that is 2 tablets of 250 milligram of chloroquine phosphate or 300 milligram base, plus primaquine 15 milligram daily for 2 weeks to provide radical cure, excluding pregnant lady. Then for extraintestinal hepatic amoebiasis, the preferred drug is metronidazole, but chloroquine may be given if metronidazole cannot be used. Rheumatoid arthritis, the indication of chloroquine in rheumatoid arthritis is due to its anti-inflammatory action. Similarly, discoid lupus erythematosus, lepra reactions, infectious mononucleosis, photosensitivity reactions, porphyria cutánea tarda, polymorphic light eruptions, and we have seen that in pandemic COVID-19, chloroquine was also used. Then we have a drug called amodiaquine, but it is used as a fixed dose combination as artemisinin based combination therapy in Plasmodium falciparum malaria. Pipraquine, it is also used as fixed dose combination, and it is formulated with dihydroartemisinin, and it is used as artemisinin based combination therapy for Plasmodium falciparum malaria. Quinine and quinidine. Oral quinine is FDA approved for the treatment of uncomplicated Plasmodium falciparum malaria, but the drug is more toxic and less effective than chloroquine. Compared to artemisinin class of therapy, quinine produces poorer clinical outcomes. Pharmacological actions of quinine include antimalarial actions, and these are rapid acting erythrocytic zygontocyte, but no significant effect on sporozoites, pre or exoerythrocytic forms of the parasites. It is gametocidal against all species of Plasmodia except Plasmodium falciparum. Other actions of quinine include direct myocardial depressant action. IV quinine can cause severe hypotension, local anesthetic action because of sodium channel blockade, local irritant action at injection site. Bitter in taste, can cause severe nausea and vomiting. Directly acting muscle relaxant, skeletal muscle relaxants. Myasthenia gravis is precipitated. Mild antipyretic and analgesic action, and some oxytocic action. ADRs of quinine include synchronism. It may be idiosyncratic on a single dose or prolonged use. Hypoglycemia can occur due to insulin release, hypotension and cardiac arrhythmias on higher doses or IV administration. Hemolysis in patients with G6PD deficiency. Hypersensitivity reactions such as skin rashes and flushing and pruritus. Black water fever is a serious hypersensitivity reaction characterized by hemolysis, renal failure, hemoglobinuria and pyrexia. Quinine can also cause toxic amblyopia and total blindness at high doses. Toxic features includes hypotension, hypoglycemia, arrhythmia, convulsions and coma. Death is due to respiratory arrest. In malaria, how to use quinine? Oral quinine is used in uncomplicated malaria and IV in severe and complicated Plasmodium falciparum cases. In uncomplicated chloroquine resistant Plasmodium vivax and Plasmodium falciparum malaria, quinine is given 600 mg 3 times a day for 7 days along with doxycycline 100 mg OD for 7 days. But in pregnant women and children below 8 years of age, in place of doxycycline, we give clindamycin 600 mg twice a day for 7 days. In severe and complicated Plasmodium falciparum malaria, IV quinine followed by oral quinine plus doxycycline or clindamycin is second choice drug except in pregnancy where it is first choice. Then some other indications of quinine are babesiosis, leg cramps, and myotonia congenita. Mefloquine, it is used for prophylaxis and for combination therapy with lumefantrine. So mefloquine is used for prophylaxis of multi-drug resistant malaria in travelers. 250 mg weekly, started 1 to 2 weeks before and taken till 1 month after return from the endemic area. And it is also used in uncomplicated Plasmodium falciparum malaria resistant to chloroquine or quinine. It is used as combination with artesunate, so artesunate plus mefloquine. It is used as ACT. One thing you have to remember that the mefloquine can cause psychotic changes and seizures. So persons having CNS adverse effects such as neuropsychiatric patients or patients of epilepsy, the drug should be preferably avoided. Then we have sulfonamides and pyrimethamine combination, and this combination is used along with artesunate, and it is the first line drug for uncomplicated Plasmodium falciparum malaria except northeast states in India. It is a preferred ACT, that is artesunate sulfonamide plus pyrimethamine for uncomplicated Plasmodium falciparum malaria. The other indication of this combination is sulfadoxine pyrimethamine combination is drug of choice for Toxoplasma gondii. Roguanil and atovaquone, these are combined as Malarone, and it is approved in some other countries for prophylaxis as well as treatment of malaria. Doxycycline and clindamycin I have already discussed. These are not used alone, these are always used along with quinine. Primaquine, this is the radical curative and gametocidal agent. Artemisinin derivatives are used as combination therapy as ACT, artemisinin based combination therapies in uncomplicated and complicated malaria, but for complicated malaria we have to use IV artesunate, that is the drug of choice. So ACT, the approved ACT in India are artesunate, sulfadoxine plus pyrimethamine, artemether and lumefantrine, artesunate, mefloquine, artesunate, pyronardine, artesunate, amodiaquine, dihydroartemisinin and piperacin, arterolane and piperacin. Artesunate sulfadoxine plus pyrimethamine is the first line ACT under National Vector-Borne Disease Control Program in India except Northeast state, where artemether and lumefantrine FDC is preferred for uncomplicated and multi-drug resistant Plasmodium falciparum malaria as well as chloroquine resistant Plasmodium vivax and ovale malaria. So I have tried to discuss important features of antimalarial drugs, and this will be helpful for you. Thank you so much.